Hello everyone, it is Dr. Nurse Tutor here. I am coming back with a new video. This video is geared towards my LPN students, any LPN students who are currently enrolled in nursing school for practical nursing or getting ready to take your NCLEX. You're looking for some study questions, trying to understand how to rationalize these questions, how to break these questions down to understand the content. A big thing for me is not trying to figure out what the right answer is understanding the content, not memorization. Because I feel more so when you understand the content, you understand the medical terminology, no matter how the question is going to be given to you, you won't have a difficult time breaking those questions down and understanding how to rationalize with those questions. So with that being said, I am going to come with roughly about 10 questions in this video. These are not next gen questions. These are more so testing questions that are going to help you, like I said, with rationalization. I am going to get into some next gen questions just to help you better understand how to break down the next gen questions. And I should have that coming in my next video for both LPN as well as BSN students who are getting ready to take their NCLEX. So I'm going to start with the first question. The first question states, select the member of the healthcare team that is paired with one of the main functions of this team member. Select the member of the healthcare team that is paired with one of the main functions of this team member. So what it's basically asking you is going to give you a list of healthcare team members and is going to pair with a specific function that is supposed to be specific to that healthcare member. And it is through the multiple choice answers, you have to choose which one matches correctly. The first option is occupational therapist, gait exercises. The second option is physical therapist, the provision of assisted devices to facilitate the activities of daily living. The third one is speech and language therapist, the treatment of swallowing disorders. And the fourth one is case manager, ordering medications and treatments. I'm going to start from the bottom. I like to sometimes start from the bottom and work my way up, or maybe start from the top and work my way down. But this time I want to start from the bottom and start with the answer choices at the bottom. The first one at the bottom, which is D, says case manager, ordering medications and treatments. I wanted to start from the bottom because I immediately knew that case managers do not order medications or treatments. Medications and treatments are usually ordered by the physician or maybe an advanced practice nurse like a nurse practitioner or the PA. Those are the only people that are usually ordering medications. So that would immediately not be the option. The next one says speech and language therapist, treatment of swallowing disorders. I like that because speech, you talk with your mouth and you swallow with your mouth. So they seem like they work, but I do want to see the other options to continue with my process of elimination. B says physical therapist, the provision of assisted devices to facilitate the activities of daily living. And A says occupational therapist, gait exercises. Now, this could be a little tricky because if you don't know what the job of a physical therapist is or an occupational therapist, you may get tripped up. Understand that occupational therapists help you with daily activities of daily living, meaning how to use a toothbrush, how to comb your hair, how to use a brush, how to use a spoon to eat, how to dress yourself, how to undress yourself. Anything that has to do with the activities of your daily living. That is what occupational therapists do. Physical therapists are responsible for getting you up and moving. Anyone who has had surgery, who may have issues with movement, issues with getting up, issues with walking, that's what physical therapy is for. They're for getting you up out of the bed and to the door, walking. as best as possible. So A says occupational therapist gait exercises, that would be walking. So automatically that would not be an occupational therapist. That would be a physical therapist, because physical therapists are responsible for getting you up and walking. Occupational therapists are responsible for your activities of daily living. So A is not correct because occupational therapists do not help you with walking, and B is not correct because physical therapists do not help you with your activities of daily living. It is actually the opposite. So the only answer that makes sense would be speech and language therapist, the treatment of swallowing disorders. You see where I broke that down? Because physical therapists do not do what occupational therapists do, and occupational therapists do not do what physical therapists do. So that's wrong. And case managers do not order medicine. So the only other answer, the only other option would be that speech therapist, treatment of swallowing disorders. All right, number 2 says the recommended daily caloric intake for sedentary older men, active adult women, and children is: A is 2,400 calories, B is 1,600 calories, C is 2,800 calories, D is 2,000 calories. Now, this is just something that you have to know, and it's basically the recommended daily caloric intake. If you turn any food product to the back and you look at the nutrition of that food product, it usually will say based off of a 2,000 calorie diet. Usually, whether if we're dealing with men, women, children, nutrition values on the back of food packages don't really focus on who is eating it. It's usually just based off of a 2,000 caloric intake, daily caloric intake. So for older men, active adult women, and children, it would be a 2,000 calorie diet for the daily recommended caloric intake. Yes, if circumstances were different, where it may have been a younger man or a younger or older woman or an older child, the caloric intake may differ. Even based off of your activity level, it may differ. People do have specific calorie intake to their age, to their gender, to their physical ability. But usually the rule of thumb is the caloric intake, anytime you're questioning as far as food intake or even just generally, it'll always be based off of a 2,000 calorie diet. Okay. Number 3 says ill health, malnutrition, and wasting as a result of chronic disease are all associated with what? Ill health, malnutrition, and wasting are all associated with what? We have surgical asepsis, we have catabolism, we have cachexia, we have venistasis. Now, surgical asepsis, if you know what surgical asepsis is, you should know that that means the environment is completely sterile. The environment is clean, the environment is free of any pathogens, the environment is free of any bacteria. There is no room for bacteria. So usually in the OR or any surgical area, those areas have to be completely sterile, clean, free of pathogens. They usually set the temperature at a certain degree level so that nothing can grow, no pathogens could live in there, no bacteria can grow, and they literally sterilize everything in that area. So that's what surgical asepsis is. So surgical asepsis would not be ill health, it wouldn't be malnutrition, and it wouldn't be wasting. The next one is catabolism. And catabolism is when... Why did I just draw a blank? I know what catabolism is a breakdown of your tissues. I was confusing catabolism with cachexia. Catabolism is a breakdown of your tissues, which is especially after a severe trauma or a crush injury. So that would actually be the breakdown of your tissues. That is catabolism. We have cachexia, and cachexia is actually known as malnutrition, ill health, and wasting. It literally says ill health in the definition. So cachexia and catabolism may confuse you, but understand that Catabolism is a breakdown of tissue. Cachexia is actually considered ill health, malnutrition, and wasting. That is cachexia. And venous just so that you know, venous is the pooling of blood. So if people are bedbound, they're not moving, anyone who's driving long distances and not getting up and walking, your blood can actually start to pool. And what that means is it slows down circulation. And when blood starts to pool and it's not moving, people are at a greater risk of getting blood clots. So that's what venous is. Blood that's not really moving, blood that's kind of pooling. Usually you'll see that in the lower extremities, and that's what increases patients' risk of getting blood clots in their legs. So venous has nothing to do with ill health or malnutrition. Surgical asepsis has nothing to do with ill health or malnutrition. If you were confused, I would expect you to be confused with cachexia and catabolism, because catabolism is the breakdown of tissues, but cachexia is actually ill health, malnutrition, and wasting. So that would be the answer, cachexia. This question is more so of understanding your medical terminology. So that's just something that you're going to have to know. You should know cachexia by now. If you're doing any of your med surg classes, you should know that by now. If you don't know, please get familiar with that word cachexia, because if you're dealing with patients in long-term care facilities, if it's a nursing home, anywhere that you're dealing with patients that are bedbound, you may have patients that do become cachexic. So cachexia is a word that you do need to know and become familiar with, as well as the other terms. That's why I chose to define them, even though they weren't the answer. All right, number 4 is select all the possible opportunistic infections that adversely affect HIV and AIDS infected patients. So all the possible opportunistic infections that would affect someone who had HIV and AIDS. There are certain infections where patients who have HIV and AIDS are susceptible to. The reason for that is, of course, HIV and AIDS is a virus, and this virus actually suppresses the immune system. And when you suppress the immune system is not as effective as it normally would be to fight against any sort of bacteria, pathogens, or anything that would invade the body and cause it to become diseased. So when people who have HIV and AIDS, their immune systems are suppressed and they're not working as effectively, which would make them susceptible to different infections and diseases. So from the list, like I said, infection or diseases, from the list, the first thing says visual loss. Visual loss, you should already see that's not an infection. That's not an opportunistic infection. Visual loss just means that the person has lost their sight or their vision, right? Kaposi sarcoma. Kaposi sarcoma is a condition where people who have HIV and AIDS are susceptible of getting. So you do have to know that. Wilms sarcoma is not one, and if I'm not mistaken, it's called Wilms tumor anyway. Wilms sarcoma is not one. Tuberculosis is most definitely one. Tuberculosis is an opportunistic infection that would affect someone with HIV or AIDS. That's a biggie. So if you don't remember anything else, please remember tuberculosis. Patients who have HIV or AIDS are susceptible to tuberculosis. Peripheral neuropathy. Peripheral neuropathy is like a numbness, tingling, like pins and needles that patients usually feel when they have poor circulation, or if they have diabetes, or if they may have peripheral vascular disease or arterial disease. They'll usually notice peripheral neuropathy. That's not an opportunistic infection. That's actually when we have irritation of those nerves that cause the numbness and the tingling and the feeling of pins and needles in the lower extremities. So that's not an infection. So visual loss and peripheral neuropathy are not options. Toxoplasma gondii, most definitely, that's an opportunistic infection that people who have HIV and AIDS may be at risk for getting. So understand that Kaposi sarcoma, tuberculosis, and Toxoplasma gondii are definitely opportunistic infections that people who have HIV and AIDS would be susceptible for getting. Number 5, what can help reduce a patient's anxiety and post-surgical pain? So, I am expecting that patients who have to go to surgery are probably going to have anxiety before going to surgery. They're probably going to have anxiety about the unknown going into surgery, and they're probably going to have anxiety after coming out of surgery. What's going to happen to me when I come out of surgery? What am I going to look like? What am I going to feel like? Am I going to have pain? So what do I need to do to help reduce my patient's anxiety after surgery, post-surgical pain? So the options are preoperative teaching, a preoperative checklist, psychological counseling, and preoperative medication. I'm going to start from the bottom because D says preoperative medication. The issue with that is it doesn't even say what the medication is. So what is the preoperative medication that we're giving that's going to reduce the anxiety? It doesn't even say that it may be an anti-anxiety medication, like maybe a benzo or maybe an antipsychotic. It doesn't even say that. It just says preoperative medication. So the fact that we don't even know what the medication is shouldn't even be an answer choice, because it doesn't make sense. What medication are we giving to reduce this patient anxiety? And also, even if we did have a medication to reduce their anxiety, what happens when that medication wears off? The patient is still going to have anxiety, so we haven't done anything for their anxiety. So that wouldn't even be a good answer choice. The next one says psychological counseling. I'm not opposed of that answer, but I do want to look at the other answer choices just to see if there's a better answer. B says preoperative checklist. The preoperative checklist, if you're familiar with the preoperative checklist is the checklist that we do to make sure that we have the right patient, we have the right site, we acknowledge the surgery that's going on, the time of the surgery, when the surgery is supposed to start, who the patient is. That has nothing to do with helping your patient's anxiety. A preoperative checklist is just something that the nurse and the doctors are responsible to do prior to the surgery. It has nothing to do with reducing your patient's anxiety. So the preoperative checklist and preoperative medication are not options that we would choose. Now we have preoperative teaching and we have psychological counseling. I like both of those answers, but I have to decide which one is the best answer. And how to do that is you have to understand when each one would be necessary. Usually, the first thing you want to do is teach your patient and explain to your patient what is about to happen to them. Because usually when you explain to your patient what is about to happen to them, that may help to reduce their anxiety. The first step to reducing my anxiety is to educate me and teach me about what's about to happen to me. In the instance to where my preoperative teaching may not be effective and the patient is still having severe anxiety, the patient is not able to relax, the patient is not able to function adequately after my preoperative teaching, then I may need to have this patient go for some sort of psychological counseling after noticing that my preoperative teaching may not have been effective. So if you had to choose between the two, you want to make sure that you've at least tried to teach and educate your patient about the procedure first before seeking psychological counseling. Because this way, we know that we have ruled out educating our patient. We have ruled out making sure that the patient understands what the procedure is about and what it is that they should expect. Because that's usually the first step. You have to educate your patient before they go for a procedure. If that's not affected, then the next step would be psychological counseling. But the first thing that you will need to do to reduce the anxiety of your patient would be that preoperative teaching. Preoperative teaching may help to reduce your patient's anxiety when they come out of surgery, when they're going into surgery and when they're coming out of surgery, because that way they should know what to expect going in and they should know what to expect coming out, especially if it's involving post-surgical pain. Number 6 says, which disease decreases the metabolic rate? We have cancer, we have hypothyroidism, we have chronic obstructive pulmonary disease, and we have cardiac failure. Now, our metabolic rate would be our metabolism, right? So I know that cancer is a virus, so cancer affects my immune system, so cancer is probably not going to affect my metabolic rate. Hypothyroidism has to do with my thyroid, and my thyroid does control my hormones, so I'm going to hold on to hypothyroidism and look at the rest. We have chronic obstructive pulmonary disease. That's COPD. COPD has to do with your lungs. It has to do with breathing. It has to do with oxygen. It has to do with CO2. So that's probably not going to affect my metabolic rate. And then we have cardiac failure. Cardiac failure has to do with your heart pumping blood to the rest of your body. Cardiac failure would be your heart's inability to pump blood effectively to the rest of your body. So I don't think that would have anything to do with the metabolic rate. The only option that really makes sense would be hypothyroidism, because of course the thyroid regulates our hormones, and of course metabolism cannot happen unless your thyroid is effectively functioning. So the only option that really makes sense would be hypothyroidism, because cancer affects your immune system. It suppresses your immune system. Chronic obstructive pulmonary disorder is COPD. It affects your lungs, your respirations, your pulse ox, your oxygen, your CO2. So that's not metabolism. And cardiac failure just means you're in heart failure. So the heart is not effectively pumping blood to the rest of your body. So the only option that really makes sense, if you really break this down and you understand what these different disorders do, the only one that makes sense would be the thyroid, hypothyroidism, as the option. All right, number 7 says, when caring for an infant during cardiac arrest, which pulse must be palpated to determine cardiac function? You are responsible for knowing that the only pulse that is usually effective with checking an infant is that brachial pulse. All the other pulses, we have a carotid pulse here, we have a pedal pulse here, we have a radial pulse here, we have a brachial pulse here. When you're dealing with infants, brachial. That's really the only pulse that you can even find on an infant is the brachial pulse. So if it's an infant, the first thing you need to go looking for is a brachial pulse. Carotid, adults. Pedal, adults. Radial, adults. Infants are not developed enough to find a carotid pulse, to find a pedal pulse, or even to find a radial pulse. You're looking for that brachial pulse when it comes to infants. All right, number 8 says the patient should be sitting when deep breathing and coughing, because this position does what? This is kind of a trick question. I've actually seen this question on exams before, and I'm going to explain to you why this is a trick question. Now, the question is talking about deep breathing and coughing. Well, in nursing, anytime you're worried about deep breathing and coughing is because you want to make sure that that patient's airway is patent, and you want to make sure that there is an exchange of oxygen and carbon dioxide effectively. You want to make sure that their respirations are normal. Those ABCs, airway, breathing, circulation. You want to make sure that airway's open. You want to make sure that they're breathing, right? So now let's look at these options. It says because it's physically more comfortable, coughing and deep breathing is physically more comfortable for the patient. B says help the patient to support their incision with a pillow. C says loosens respiratory secretions, and D says allows the patient to observe their area and relax. I'm going to actually start with D. I like to start with the one that I can just cross out. D says allows the patient to observe their area and relax. Nothing about deep breathing and coughing is going to allow your patient to observe their area and relax. The reason why they put that there is because we do know that deep breathing is a relaxation technique. But what the question is asking is about deep breathing and coughing. So don't be confused about this and think that this deep breathing is about relaxation. This deep breathing and coughing is about your airway, breathing, and circulation. That should be what you're always thinking about. So that's the reason why D needs to go. Okay? C says to loosen respiratory secretions. I'm going to hold on to that. B says help the patient to support their incision with a pillow. You need to hold on to that too, and I'm going to tell you why. A says is physically more comfortable for a patient. The reason why it's not A is because there are different reasons why your patient may need to deep breathe and cough. If your patient has pneumonia, they would need to make sure that they're deep breathing and coughing. If your patient has the flu, tuberculosis, any lower respiratory diseases or infection, your patient has to deep breathe and cough. The issue with that is when you have pneumonia, when you have the flu, if anyone has ever had that before, think about when you've had it. It hurt to cough. It hurt to deep breathe. Every time you coughed, it hurt your chest. Every time you try to take a deep breath in, it hurt. So what are patients naturally going to do? Not deep breathe and not cough. Think about coming from surgery. If you've ever come from a surgical procedure, the first thing they want you to do is deep breathe and cough. You're not going to want to do that because all you're going to think about, if I deep breathe and cough, is going to hurt. The problem with that is if you don't deep breathe and you don't cough, we're not going to have a good air exchange, which could lead to things like respiratory acidosis, where your patient is holding on to too much carbon dioxide. So that's what we need to be thinking about when we're thinking about deep breathing and coughing. So it's not physically comfortable, because if someone came from surgery or if someone has a lower respiratory disorder or infection, it would be very uncomfortable to cough and deep breathe. So A and D, I'm going to cross those two out. Now I'm left with help the patient support their incision with a pillow and loosen secretions. Coughing and deep breathing does not loosen secretions. Remember from class when they say drinking fluids helps to loosen secretions. Certain medications like mucolytics, the Mucinex, things like that, that'll help to loosen your secretions to help to cough them up, right? But this is not going to help to lose. Coughing and deep breathing is not going to help to loosen secretions. There are certain medications and drinking liquids that will help to loosen your secretions. The answer is to help the patient support their incision with a pillow. I know you're looking like, what does an incision have to do with anything? The question doesn't say anything about surgery. The problem is, surgery is one of the most important times when deep breathing and coughing is important for your patient. The reason for that is a lot of patients receive anesthesia. And when they receive anesthesia, they're breathing through a machine. When that anesthesia wears off, we have to make sure that our patients are breathing effectively. Those lungs wake back up. These patients are taking deep breaths in and exhaling an equal amount of oxygen and carbon dioxide for an adequate pulse ox and adequate respirations. So when you're thinking about deep breathing and coughing, if you see an answer like incision and pillow, the reason for that is that patient is already expected to be in pain. When they come out of a procedure, they're already expected to be in pain. So the best way to get them to cough and to deep breathe is by giving them a pillow. And whenever they cough or whenever they deep breathe, they can use that pillow to support them to help support the blow of the deep breathing and the coughing, because it's going to be uncomfortable when they do it. That's the reason for that. I don't care if it's pneumonia. I don't care if it's the flu. I don't care if it's COVID. I don't care if it was a surgery. The reason for using that pillow is to help to support the blow of the cough, because it's going to be uncomfortable. And usually when patients cough and deep breathe and it hurts, they don't want to do it again. They're going to do everything to avoid it. So by providing them a pillow with coughing and deep breathing, that's going to help to support the discomfort of the coughing and the deep breathing. That's how I want you to think about it. Coughing and deep breathing in healthcare usually has to do with patients who are at risk for decreased respirations or a decreased pulse ox. And understand that when we have decreased respirations and a decreased pulse ox, that patient is at risk for respiratory acidosis. And you already know that that's a life-threatening acid-base imbalance. So that's how I want you critically thinking when you look at questions like this. That's the reason why that pillow answer is very important in this question. All right. Number 9 says, which procedures necessitate the use of surgical asepsis? Surgical asepsis means no bacteria can enter this area while you're doing the procedure. Sterile field, sterile everything, sterile procedure all the way through from the beginning to the end. Which procedure would necessitate the use of surgical asepsis techniques? The first one is an intramuscular medication administration. Usually we just need a set of clean gloves, some alcohol, you clean the site. That's not asepsis. That's just a clean technique. B says central line intravenous medication administration. That is asepsis. The reason being is that central line is either going into an artery or a very large vein. So you have to make sure that you're using aseptic technique, whether you're inserting it or you're cleaning it or you're putting medication in it. The reason being is those large veins and those large arteries are very close to the heart, and usually is in this subclavian area, which is very close to your heart. So you want to make sure that you are using an aseptic technique whenever you're handling a central line. Donning gloves in the operating room, anything that has to do with the operating room is sterile. There is nothing that is clean procedure in an operating room. Everything is sterile. So donning gloves in the operating room would be an aseptic technique. Neonatal bathing, you may just need a pair of clean gloves, a towel, and some soap. So that is a clean procedure. You don't need asepsis with an aseptic technique with neonatal bathing. The Foley catheter insertion, the bladder is sterile. The bladder is sterile. It's a sterile field. When you are inserting a Foley, that is an aseptic technique. If you don't know anything else, know that that Foley catheter insertion is aseptic technique. Emptying a urinary drainage bag is not an aseptic technique because you're just emptying the urine. Once the urine comes out of the bladder, it's no longer aseptic, so you don't have to empty a urine drainage bag with an aseptic technique. Just understand, inserting that Foley into the bladder is an aseptic technique. Going into the OR, aseptic technique at all times. Anything you're handling is aseptic. And central lines, like I said, very large veins or arteries, and it's usually in the subclavian area. That's an aseptic technique. 10, which will be my last question, says, what is the ultimate purpose and goal of performance improvement activities? Performance improvement activities. What is the ultimate purpose? The first one says to increase efficiency. The second one says to contain costs. The third one says to improve the process. And the fourth one says to improve the policies. This is a good question. I want to look at A first. A says to increase efficiency. Efficiency means how well you can do it. But the problem with that is, what if I am efficiently doing the wrong thing. Is how you have to think about it. Because if I'm following a procedure that somebody is doing because it just works for them, it's not a policy of the hospital. It's just a procedure that a whole bunch of nurses started doing. It was effective for them, and I became efficient in doing something that was not deemed appropriate by the facility, and then something happens to the patient. Efficiency doesn't always mean that it's right. It just means that you're doing a good job at doing something, and you can very easily do a good job at doing the wrong thing. So that's the reason why efficiency is not correct. B says to contain costs. We always want to contain costs in the hospital, but we don't want to contain costs if it's not effective or if it doesn't improve the healthcare, because people will try to cut corners. And if we start cutting corners and it's at the cost of the patient, containing costs is not a good thing. So understand that containing costs could mean that we're doing it without the patient in mind and just doing things to cut corners. And that's not effective when it comes to performance improvement. Now we have to improve the process and we have to improve the policy. Those are both good answers, but which one is more important? Which one would come first is what I'm thinking about. We have improved the policy, improved the process. The policy, in my eyes, the policy can't be improved until we improve the process, because the policy is what contains the process. So as the process changes, the policy changes, because the process is literally the step-by-step instructions on how to do something. And once you have the step-by-step instructions of how to do something, that's when you can create the policy. So if we had to choose the best answer, it would be to improve the process, because processes are always changing. If you ever look at it, policies that we have in the hospitals change because the process of the procedure is changing. When I was working in the hospital, I worked on a floor where we dealt with central line dressings, and those policies were constantly changing, and they were changing because what was in place, it wasn't bringing down the rate of central line infections. So the process, the step-by-step process had to change, and whenever the step-by-step process changed, the policy changed. Fall risk patients, they would always come up with a new study about how to decrease the risk of falls. Then we will take on this policy that had a step-by-step process on how to decrease the risk of falls. And if a patient would fall, the process had to change. And the process, while the process was changing, the policy wouldn't change until the whole process changed. Once the process changed, then they created a new policy. So if you had to choose the correct answer, it would be you have to improve the process before you can improve the policy. So the answer would be to improve the policy as a goal of performance. Don't confuse. I don't want to confuse you. The answer is to improve the process, to improve the performance for the goal of improving the performance activities. So it would be to improve the process. You have to improve the process before you can improve the policy. Okay? So I'm going to stop there. We just went over 10 questions. These are more like test taking strategy questions. I am going to, like I said, get into a little bit of next gen. Break that down. Next gen, I do enjoy next gen. I have seen some next gen questions, and it's more so of storytelling, and it's breaking down the question. Like a patient may come in and you're not really sure what the patient's coming in with. The patient is showing a number of symptoms, and you literally will get questions according to the patient's symptoms and how you're going to take care of that patient all the way through. from not knowing what they come in with to figuring out what they come in with and how that treatment plan of that patient is going to be. So be on the lookout for the next gen questions that will be coming in future videos. I hope that this video was helpful to help you kind of rationalize and understand the questions that may be coming to you, whether it be in a test or even on the NCLEX when you go to take the NCLEX. I will have more videos coming, so definitely stay tuned. And I hope you enjoyed this video, and I hope that it is helpful, but I will see you soon. Bye-bye.